Bismillahirrahmanirrahim. In this video I am going to cover a very important topic, and that is wide complex tachycardia and the algorithm we must follow when a patient presents with wide complex tachycardia, whether it's ventricular tachycardia or the other differentials like supraventricular tachycardia with phasic aberrancy or supraventricular tachycardia with pre-existing ventral branch block, or the pre-excitation pattern with different kind of tachyarrhythmias. But one thing we must remember always, that whenever patient presents with wide complex tachycardia, it should be considered as a ventricular tachycardia and treated accordingly unless and until proven otherwise. Our algorithm. First we have to document it as a wide complex tachycardia, that is the QRS duration is more than 120 milliseconds or 3 small squares. First we have to look whether it's regular or irregular. If it's irregular, it's not ventricular tachycardia. It's either atrial fibrillation or atrial flutter or atrial tachycardia with variable conduction. So in case of regular wide complex tachycardia, first we have to look at the QRS complex. Is it just identical to that of the complexes present in a sinus rhythm ECG strip if it's available? If yes, then we may consider it as an SVT with bundle branch block or SVT with antidromic ABRT, which has been discussed in the other video as well. So second thing is we can perform vagal maneuver, the carotid sinus massage, or even we can give an adenosine injection. If it reverts back to normal sinus rhythm, it is most likely it's not VT, it's an SVT. Or if there is a history of previous myocardial infarction or a known structural heart disease, then again we can think of most likely it's ventricular tachycardia. And then we come to the AV relationship, the one-to-one AV relationship, which is present here. It means that every QRS complex is followed by a P wave. If every one QRS complex is followed by one P wave, it means it's a one-to-one AV relationship. If it's not present and the ventricular rate is faster than the atrial rate, most likely it's ventricular tachycardia. And because we know it very well that in case of ventricular tachycardia there is AV dissociation, and it's one of the very important hallmark of ventricular tachycardia when differentiating it to a supraventricular tachycardia with aberrancy or any other differential. So the next thing is we'll look at whether the atrial rate is faster than the ventricular rate or not. If it's faster, then most likely it's atrial tachycardia or atrial flutter with some other reason of the wide complex of the QRS complex, again due to some bundle branch block or pre-excitation or anything like that. So if there is one-to-one AV relationship and the QRS morphology in the precordial leads is typical of RBB or LBB, most likely it's SVT. All these things, these parameters which are discussed in this final row in green color, I will be discussing it with examples and figures later in this video. So for now, just remember that if the morphology of the QRS complex is typical of RBB or LBB, it's most likely SVT. And if the precordial leads, they're concordant, whether positive concordance or negative concordance, it's ventricular tachycardia. If there is no RS pattern in the precordial leads, again it's ventricular tachycardia. If the onset of R wave to the nadir of the S wave is longer than 100 milliseconds, it's ventricular tachycardia. If RBB pattern is there but there is QR or RS or RR in V1, our frontal plane axis ranges from plus 90 degrees to minus 90 degrees, again it's ventricular tachycardia. And if there is LBB pattern but there is an R in V1 that is longer than 30 milliseconds, it is ventricular tachycardia. Or if the R to S wave nadir in V1 is greater than 60 milliseconds, is ventricular tachycardia. Or if there is small QR or small QS in V6, again it's ventricular tachycardia. Now let us go to the examples and the figures of these patterns that we have been discussing. Just focus on the precordial leads. We can see that there is negative concordance of the QRS complex in all the precordial leads, and what that actually means that the QRS complex is in the negative direction in all these leads. So this is one of the criterias. The concordance in precordial leads is one of the criterias to label ventricular tachycardia. If all these QRS complexes were upwards from V1 to V6, it would have been called as a positive concordance, and any positive or negative concordance in the precordial leads is a criteria to label as ventricular tachycardia. Now this figure actually demonstrates the RS interval calculation, and it starts from the onset of the R wave and up till to the nadir of the S wave. Nadir is the point which is the deepest point in the S wave. If this type of RS pattern is present in any precordial lead and the RS interval is more than 100 milliseconds, then it's most likely a ventricular tachycardia. As far as the morphology of the QRS complexes are concerned, if they are typical of RBB or LBB, then most likely it's SVT and not ventricular tachycardia. And just see in these figures, the upper figure demonstrates the morphology of the RBB in V1. We can see that the right rabbit ear is taller than the left rabbit ear, and the QRS is broad and T-wave inversion and all those. These are the typical findings of an RBB. And in the lower figure, again V1 is mentioned here, and just see that there is a deep S wave and a prominent T-wave after the QRS complex. And so these are the typical features of RBB and LBB. But if the RBB is present but the complexes are something like this, that is demonstrated in these figures. For example, if the R wave is smooth or it is not, and the RS interval is more than 100 milliseconds or 2.5 small squares, or just focusing on the lower this figure, the left rabbit ear is taller than the right rabbit ear, or if there is a QR pattern, a small q capital R pattern, in which a small q wave precedes the R wave, and the RS interval again it is more than 100 milliseconds. If these findings are present, then most likely it indicates a ventricular tachycardia rather than an SVT. Now similarly, if we focus on the V6 lead and just suppose that it's like this, that there is a QS complex, a capital Q capital S complex. What does that actually mean? That there is a completely negative complex with no R wave, then most likely it's ventricular tachycardia. Secondly, if there is a small R wave and a deep S wave, just like in this figure, and the RS ratio is less than 1. Just focus on this video that there is a small R wave preceding the S wave, and it's less taller than the S wave length, so the RS ratio is less than 1. So it also signifies a clue that it's most likely ventricular tachycardia. Now another point that we have already discussed in our algorithm, that in case of LBB, if in V1 or V2 the R wave interval is more than 30 milliseconds, or the R to nadir of S wave interval is more than 70 milliseconds, it will be labeled as a ventricular tachycardia. So this is a representation of that point. This figure, the A denotes the R wave interval here, which is more than 30 milliseconds, and this C denotes the R to S wave nadir interval, that is more than 70 milliseconds. And additionally, if there is a notch in the downstroke of the S wave, all these points favor towards the diagnosis of ventricular tachycardia than an SVT. So in a real ECG in V2, all these points are labeled and present, so our diagnosis will be most likely a ventricular tachycardia. The R wave is more than 30 milliseconds, there is not S wave downstroke, and the RS interval is more than 70 milliseconds or more than 1.75 small squares. Now again, this point we have already discussed in our algorithm, that with an LBB like pattern, the presence of Q waves in V6 is indicative of ventricular tachycardia. There are two possible patterns. The number one is capital QS waves in V6, which is shown in the upper figure here, the deep downward waves. Such waves are called the QS wave. Previously we have discussed it in V1 lead. Now we are focusing on V6, and as we know that in case of LBB, ideally these complexes should be upwards, but if the patient is having LBB but these complexes are downwards, and such QS pattern which is shown in this upper figure in V6, they're present, then most likely the diagnosis is ventricular tachycardia. And the second possibility, that although there is an R wave, but there is an initial Q wave which is shown in this figure, a small Q wave. Small Q wave means that its amplitude is less than the R wave. So again, it will be favoring our diagnosis towards ventricular tachycardia rather than an SVT. So it's mentioned here, note, SVT with LBB is associated with absent Q waves in V6, which we have already discussed. Another point that is important regarding the differentiation of VT to SVT is that in case of VT there are capture beats and fusion beats that can be present in the ECG. So if the capture beats and fusion beats are present, which are shown in this figure, then most probably our diagnosis moves towards the ventricular tachycardia. There is another criteria to differentiate the VT from SVT or ABBRENCY, that is called an AVR criteria. So just focus on lead AVR. and if there is a presence of an initial R wave in lead AVR, then it's VT. If not, then we'll look for the presence of an initial R or Q wave. If any one of them is more than 40 milliseconds, is it's ventricular tachycardia, and if it's not, then we look for the presence of a notch on the descending limb of a negative onset and predominantly negative QRS. If it's present, then it's ventricular tachycardia. If it's not, then we look at the vertical excursion of the initial and the terminal portion of the QRS complex, and if its ratio of initial to terminal portion of the QRS complex of the vertical excursion is less than 1, it's labeled as ventricular tachycardia. If it's not, then most probably the diagnosis moves towards SVT. So in this video I have tried my best to explain the differences in ventricular tachycardia and the other differentials of the wide complex tachycardia. So there are so many criteria that are mentioned in different books and with different names, like Brugada criteria and AVR criteria, which we have discussed, and so many other names as well. But the main thing is that we must know the basics and the morphological aspects that we come across while looking at a wide complex tachycardia. So most of those criterias which are present in different books with different names, they are discussed in this video lecture, and I hope this will be beneficial to all who have listened this lecture. Thank you very much.